Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. In today's video, we delve into the world of lymphoid neoplasms and explore the essential aspects of diagnosis. We'll also shed light on the morphologic and immunophenotypic features of normal lymph nodes. So, let's get started. Lymphomas are the cancers that initiate in the lymphoid system. These cancers closely resemble specific stages of normal lymphoid development, and we confirm this through microscopic observations, immunophenotypic studies, and molecular analysis. Diagnosing lymphomas involves a combination of factors, including their biological characteristics, morphology, immunophenotype, genetic features, and clinical information. To ensure an accurate diagnosis, it's imperative to preserve and make tissue available for microscopic examination and specialized studies during the initial sample processing. A solid understanding of how normal lymphoid cells develop is essential for comprehending lymphoid cancers. Lymphoid organs play a pivotal role in recognizing, processing, and generating lymphocytes in response to antigens. Lymph nodes, often oval or round and encapsulated, are vital hubs for immune responses. They are especially prominent at sites where the body interacts with the external environment. Lymph nodes are found in large groups, such as cervical, axillary, or inguinal nodes, which drain specific peripheral areas. Internal organs have their regional nodes, like mediastinal, hilar, and mesenteric nodes. Additionally, the respiratory and digestive tracts have clusters of lymphoid tissue within their mucosal lining, known as mucosa-associated lymphoid tissue, MALT. These MALT regions are primary sites for encountering antigens and channeling them directly into regional lymph nodes. When examining a lymph node structure, we find various components, including the cortex, paracortex, medullary cords, and sinuses. These components serve both structural and functional purposes, acting as sites for specific antigen-driven immune reactions. We're delving into the fascinating world of the lymph node cortex. We'll explore the intricate details of this vital part of the lymph node, from primary follicles to plasma cells. So, let's get started. The lymph node is like a fortress, encapsulated by fibrous tissue. Just beneath this capsule, you'll find the cortex, a crucial region filled with essential components. Primary follicles within the cortex are home to small, naive B lymphocytes expressing CD19, CD20, and often CD51. Secondary follicles are where the action intensifies, hosting germinal centers. These centers are supported by intricate follicular dendritic cell meshworks, detectable with CD21 staining. When naive B lymphocytes encounter antigens, they undergo a remarkable transformation. They proliferate and differentiate into plasma cells and memory B cells. Germinal center B cells express specific markers like CD10 and BCL6. Importantly, they lack the BCL2 protein, setting the stage for further development. Inside the germinal center, there's a dark zone housing centroblasts. These are central to somatic mutations that enhance antibody affinity. Centroblasts don't stay the same, they become centrocytes in the light zone. Those with low affinity immunoglobulins undergo apoptosis. A fascinating process unfolds as germinal center macrophages phagocytize apoptotic centrocytes, creating a unique, starry sky appearance. High-affinity centrocytes continue their journey, evolving into memory B cells in the mantle zone. At the mantle zone periphery, we have the intriguing marginal zone lymphocytes. They stand out with clear cytoplasm and indented nuclei. Our journey in the cortex eventually leads to the formation of plasma cells. These cells play a crucial role in the immune response, but they have their unique characteristics. The paracortex is a significant region situated between the follicles and extending towards the medullary cords within lymph nodes. Its primary mission: to produce mature and functional T cells. This region is mainly occupied by T cells, interdigitating dendritic cells, the antigen presenters to T cells, and high endothelial venules, which are specialized blood vessels allowing lymphocytes from the peripheral blood to enter the lymph nodes. T cells in the paracortex express a variety of pan-T cell antigens like CD3, CD5, CD2, and CD7, including CD4 and CD8. In this bustling hub, you'll find both CD4+ and CD8+ T lymphocytes. Much like B cells, T cells undergo an incredible transformation when exposed to antigens. This process leads to small lymphocytes becoming immunoblasts, which are larger lymphoid cells with distinct characteristics. Moving deeper into the lymph node, we arrive at the medulla. It surrounds the hilum and plays a vital role in the immune response. Inside the medulla, we find medullary cords housing plasma cells. These are the powerhouses responsible for producing antibodies, crucial for our defense. Medullary sinuses are specialized channels within the lymph node that contribute to the filtration of lymphatic fluid. Lymphatic fluid filtration within lymph nodes involves a complex network of channels. Afferent lymphatic vessels communicate with a subcapsular sinus located just beneath the lymph node's capsule. The subcapsular sinus drains into cortical sinuses running through the cortex of the lymph node, eventually emptying into medullary sinuses. Within these sinuses, you'll find macrophages or sinus histiocytes, which play a crucial role in capturing and processing antigens. This is where the immune response initiation begins. Lymph node processing, a vital step in diagnosis. When it comes to diagnosing lymphomas, the examination of excised lymph nodes is a critical step. It involves various techniques and meticulous attention to detail. During the processing of lymph nodes, it's essential to maintain tissue integrity and prevent drying. This can be achieved by using appropriate transport conditions and sealed sterile containers with moistened gauze or tissue culture media. To get a closer look, fresh lymph nodes are sliced into 3 mm sections for structural evaluation. In cases where granulomas or suppuration are present, a portion of the tissue is sent for cultures. Touch imprints are prepared to assess specimen adequacy and conduct special studies. These imprints are either fixed or air-dried for staining. Immunophenotyping, a crucial part of the diagnostic process, is typically performed on paraffin-embedded tissue or using flow cytometry. Proper thin sectioning is essential to ensure tissue permeation and fixation. Some sections are placed in 10% buffered formalin, while others are fixed with special fixatives for cytologic preservation. A portion of the lymph node is placed in culture medium for flow cytometry, and the remaining fresh tissue can be stored at -70°C for further studies. Reactive lymphadenopathies, understanding lymph node enlargement. Lymphadenopathy, or lymph node enlargement, can result from various conditions. Today, we're focusing on reactive lymphadenopathies, which involve the expansion of normal lymph node structures. Lymphadenopathy, or lymph node enlargement, can result from benign/reactive or malignant conditions. Reactive lymphadenopathies can be categorized into several patterns: follicular, paracortical, sinusoidal, and mixed. Each pattern offers unique insights into the underlying cause of lymph node enlargement. The follicular pattern is characterized by follicular hyperplasia and is the most common form of reactive lymphadenopathy. It's often seen in children, adolescents, and adults and is associated with various factors, including infections, autoimmune disorders, syphilis, and early HIV infection. Microscopically, this pattern shows the prominent expansion of reactive follicles, which can extend into the medulla. Secondary follicles exhibit characteristics of reactive germinal centers, including distinct polarization, tingible body macrophages, abundant mitotic figures, and preserved mantle zones. Paracortical expansion is associated with viral infections, drug reactions, and certain skin diseases like dermatopathic lymphadenopathy. The paracortex contains small lymphocytes, immunoblasts, increased mitotic activity, and vascular proliferation. Dermatopathic lymphadenopathy presents a mottled appearance with large cells, histiocytes, melanin pigment, and Langerhans cells. It's a unique subtype of the paracortical pattern. Enlarged subcapsular, cortical, and medullary sinuses are common in lymph nodes draining various regions and in response to inflammation or malignancy. Prominent sinuses can contain histiocytes or monocytoid B cells, particularly in conditions like HIV-associated lymphadenopathy and toxoplasma lymphadenitis. They play a vital role in evaluating certain malignancies. Mixed pattern hyperplasia, often seen in conditions like Toxoplasma gondii infection, involves the expansion of all lymph node compartments. This includes follicles, paracortex, histiocytes encroaching on germinal centers, and expanded sinuses. Specific monocytoid B cells can be found in the sinuses in this condition. Lymphoma, a prevalent diagnosis. In the United States, lymphomas are a significant health concern, with approximately 86,000 new cases diagnosed each year. They can affect individuals with no prior health issues, making it crucial to understand their risk factors. The primary risk factor for lymphoproliferative disorders is compromised immune function. This can be seen in immunocompromised individuals or those with autoimmune diseases. Additionally, certain viral and bacterial infections are linked to a higher risk of lymphoma development. Exposure to certain chemicals and herbicides has also been associated with an increased predisposition to lymphoid neoplasms. Understanding these factors can aid in prevention and early diagnosis. Most lymphomas initially present in lymph nodes, but some types have a preference for extranodal sites. The involvement of bone marrow and peripheral blood, leukemic phase, varies depending on the subtype of lymphoma. Over the years, various classification systems for lymphomas have been proposed, primarily based on morphology and clinical characteristics. However, with advancements in our understanding of the immune system and molecular events in lymphomagenesis, classifications now consider morphology, immunophenotype, molecular genetics, and clinical and laboratory characteristics. A comprehensive lymphoma diagnosis requires integrating these diverse features. This holistic approach allows healthcare professionals to tailor treatment strategies to individual patients. Lymphomas can be categorized into those originating from lymphoid precursors and those arising from mature lymphoid cells based on their cellular origin. This classification helps guide clinical decisions and treatment approaches. Mature B-cell lymphomas are a diverse group, arising from various stages of B-cell development and showcasing a wide range of morphological and immunophenotypic features. Among the diverse subtypes, the most prevalent ones are follicular lymphoma and diffuse large B-cell lymphoma, DLBCL. These lymphomas frequently affect lymph nodes, with a higher incidence in the elderly, but they can manifest in leukemic forms across various subtypes. CLL and SLL are unique entities characterized by the accumulation of small lymphoid cells in peripheral blood, bone marrow, and lymphoid organs. While their exact cellular origins remain a mystery, gene expression profiling suggests their connection to antigen-experienced B cells. Interestingly, these conditions are considered one entity with differing clinical presentations by the World Health Organization, WHO. CLL primarily presents in peripheral blood and bone marrow, while SLL mainly involves lymph nodes and other lymphoid organs. In CLL, bone marrow and peripheral blood films reveal small lymphoid cells with distinctive characteristics, coarse chromatin, inconspicuous nucleoli, and scant cytoplasm. A peculiar feature in CLL is the presence of smudge cells, not typically seen in other lymphoma subtypes. In SLL, lymph nodes display a diffuse proliferation of small lymphoid cells, along with pseudofollicles composed of medium and large lymphoid cells. Diagnosing CLL relies on identifying a sustained increase in monoclonal B lymphocytes with the CLL immunophenotype. This immunophenotype is defined by the expression of specific markers, including CD19, CD20, CD23, and the unusual presence of CD5. Notably, CLL cells exhibit weaker CD20 and CD79B expression compared to normal B cells, and they display clonal light chain restriction. CLL/SLL predominantly affects older adults, though it can affect younger individuals too. Patient outcomes can vary, with some experiencing indolent disease, especially those with mutated IGVH, and others facing a more aggressive form, primarily in cases with unmutated IGVH. Prognosis information is obtained through screenings for chromosomal abnormalities, such as FISH, and by assessing genetic mutations like EZH2, Notch1, SF3B1, and BRC3. Approximately 5% of CLL/SLL patients may develop Richter syndrome, transforming into a high-grade diffuse large B-cell lymphoma with a challenging prognosis. Prolymphocytic leukemia, or PLL. This mature lymphoid leukemia can originate from both B or T cells and involves various body compartments. We'll cover its diagnosis, morphological features, and clinical aspects, so let's get started. PLL is an uncommon mature lymphoid leukemia that can stem from either B or T cells. Both B-cell and T-cell PLL types affect peripheral blood, bone marrow, and spleen, with T-cell PLL showing a higher incidence of lymph node involvement. A crucial diagnostic criterion is that over 55% of circulating lymphoid cells must display the morphology of a prolymphocyte. B-cell PLL is characterized by medium-sized prolymphocytes featuring a round nucleus, abundant cytoplasm, and a distinctive, punched-out nucleolus. These prolymphocytes are larger than normal lymphocytes, making them distinguishable from CLL/SLL. Peripheral blood involvement is significant, often resulting in a high white blood cell count. In the bone marrow, there's interstitial and/or nodular proliferation of prolymphocytes. B-cell PLL typically tests positive for CD20, CD19, CD22, and FMC7, with higher CD20 in surface light chain density than CLL/SLL. Some cases may also be positive for CD5. T-cell PLL exhibits less distinct morphological features. Neoplastic cells are small to medium-sized, characterized by round or irregular nuclei, which can resemble Sézary cells in some cases. Prominent nucleoli are seen in some instances, and cytoplasmic blebbing is common. T-cell PLL involves various sites, including bone marrow, spleen, lymph nodes, and occasionally the skin. T-cell markers like CD3, CD2, and CD5 are positive, along with CD7. Most cases express CD4, although a minority can be CD4 and CD8 double positive. PLL primarily affects the elderly, with a mean age of presentation around 70 years. Unfortunately, the overall prognosis is generally poor. B-cell PLL patients typically have a median survival of approximately 3 years. In contrast, T-cell PLL is highly aggressive, with a median survival of about 1 year using conventional chemotherapies. However, there is hope as treatment with the monoclonal antibody therapy alemtuzumab against CD52 has shown promise in improving response and survival rates in T-cell PLL patients. We're delving into the intriguing world of hairy cell leukemia. This rare condition is characterized by unique features in its morphology and immunophenotype. We'll explore what sets it apart, its clinical aspects, and prognosis. So, let's jump right in. Hairy cell leukemia is quite distinct, characterized by small B lymphocytes with abundant cytoplasm and fine, hairy, projections. Its suspected origin is the peripheral B cell, post-germinal center stage, often referred to as a memory B cell. Hairy cell leukemia cells primarily inhabit the bone marrow and the red pulp of the spleen, with only a low number typically found in the peripheral blood. Lymph node involvement is relatively rare. In the bone marrow, you'll find small to medium-sized lymphoid cells with distinctive features, including oval or indented nuclei, abundant cytoplasm, and those fine, hair-like cytoplasmic projections. Immunophenotypically, typical cases of hairy cell leukemia test positive for B-cell markers like CD19, CD20, and CD22. However, they also exhibit bright expression of CD11C, CD25, CD103, TRAP, tartrate-resistant acid phosphatase, DBA, 44, CD123, and annexin A1. Of these, CD123 and annexin A1 are specific markers for classic hairy cell leukemia, helping to set it apart from other conditions. It's important to note that TRAP staining, which was previously used for diagnosis, has now been replaced by immunophenotyping with these specific markers. Hairy cell leukemia is a rare condition that typically affects middle-aged individuals, with a median age of 55 years. Common signs at presentation include splenomegaly and pancytopenia. The good news is that durable remissions can be achieved using purine analogs, while conventional lymphoma therapy tends to be ineffective. Mantle cell lymphoma, a lymphoproliferative disorder characterized by some unique features. We'll explore its distinct morphology and immunophenotype, its clinical aspects, and the prognosis associated with this condition. Let's dive in. Mantle cell lymphoma is an intriguing lymphoproliferative disorder, recognized by medium-sized lymphoid cells with irregular nuclear outlines originating from the follicular mantle zone. This condition typically takes center stage in the lymph nodes but can also involve various other sites like the bone marrow, peripheral blood, spleen, and the gastrointestinal tract. In lymph nodes, it replaces the normal nodal architecture with a diffuse proliferation of medium-sized lymphoid cells displaying those irregular nuclear outlines. In peripheral blood, it can bear a resemblance to prolymphocytic leukemia, PLL. Mantle cell lymphoma expresses pan-B cell markers, including CD19 and CD20, and features high-density clonal surface light chains. It also co-expresses CD5 but lacks CD23 expression. Interestingly, unlike CLL/SLL, mantle cell lymphoma shows strong CD20 and light chain expression and demonstrates immunoreactivity for cyclin D1 and SOX11. In the majority of cases, a cytogenetic abnormality, T11:14, involving the cyclin D1 gene, is present. Cyclin D1 negative cases often express SOX11, which serves as a diagnostic and prognostic marker. Mantle cell lymphoma is known for its aggressiveness, with a median survival typically ranging from 3 to 5 years. Most patients present with disseminated disease, often including bone marrow involvement. It's essential to understand that current chemotherapy options may not cure the disease. However, there's hope as stem cell transplantation has shown success in some cases. We're shining a spotlight on follicular lymphoma, a condition that originates from germinal center B cells and often mirrors the follicular architecture. We'll explore its distinctive morphology and immunophenotype, the clinical features, and the prognosis associated with this particular lymphoma. Let's get started. In follicular lymphoma, you'll find closely spaced follicles that tend to replace the normal nodal structure. Unlike reactive secondary follicles, follicular lymphoma lacks mantle zones and polarization. Neoplastic follicles are comprised of medium-sized lymphoid cells resembling centrocytes and may also include larger lymphoid cells resembling centroblasts. It's graded based on the average number of large cells per high-power field, with grade 1 to 2 featuring scattered large lymphocytes and grade 3 containing numerous centroblasts. Immunophenotypically, it expresses pan-B cell markers like CD19 and CD20, along with CD10, BCL6, and clonal surface immunoglobulin. Neoplastic cells also express the BCL2 protein, contributing to their resistance to apoptosis due to the T14, 18, Q32, Q21, cytogenetic abnormality. Follicular lymphoma is typically diagnosed around the age of 59. Most patients present with disseminated disease, and approximately 50% have bone marrow involvement. The disease course varies, being indolent in grade 1 to 2 cases, while grade 3 cases are more aggressive and require treatment akin to diffuse large B-cell lymphoma, DLBCL. Extranodal marginal zone lymphoma of MALT, or MALT lymphoma for short. This subtype originates from marginal zone cells of mucosa-associated lymphoid tissue and comes with its unique characteristics. We'll explore what causes and associates with MALT lymphoma, its distinct morphology and immunophenotype, clinical features, and prognosis. Let's get started. MALT lymphoma, or extranodal marginal zone lymphoma, has its roots in marginal zone cells of mucosa-associated lymphoid tissue, giving it a distinct identity. This lymphoma subtype often finds itself linked to autoimmune conditions like Sjogren's syndrome or Hashimoto thyroiditis, as well as infections like Helicobacter pylori gastritis or hepatitis C. The persistent immune stimulation caused by these conditions can pave the way for the development of MALT lymphoma. Interestingly, antibiotic therapy to eradicate associated infections can lead to remission in some cases. In MALT lymphoma, you'll typically find a mix of medium-sized lymphocytes, plasma cells, and scattered large lymphoid cells. The predominance of medium-sized marginal zone cells with irregular nuclei is quite common. One of its characteristic features is lymphoepithelial lesions, where neoplastic lymphocytes invade glandular epithelium. Immunophenotypically, neoplastic cells express CD20, CD19, and monoclonal immunoglobulin chains, while CD5 and CD10 are notably absent. CD43 antigen may be co-expressed in some cases, and clonality confirmation is often done through flow cytometry or PCR analysis of immunoglobulin heavy chain (IgH) gene rearrangements. Some cases exhibit the T11, 18, Q21, Q21 translocation, which involves the apoptosis inhibitor gene API2 and the MLT gene. MALT lymphoma has a preference for the gastrointestinal tract, although other primary sites can include the lung, thyroid, ocular adnexa, and breast. It's typically localized to a primary site and regional lymph nodes, with bone marrow involvement being less common. Antibiotic treatment for H. pylori-positive gastric MALT lymphoma can induce remission, and local therapy may benefit other cases. Plasma cell neoplasms. These conditions are characterized by the monoclonal proliferation of plasma cells, and they can present as localized or disseminated processes, often involving the bone marrow and bone. We'll explore specific entities like plasma cell myeloma, morphology, immunophenotype, clinical features, and plasmacytoma. Let's get started. Plasma cell neoplasms are disorders characterized by the proliferation of terminally differentiated B cells called plasma cells. The specific clinical features and the primary site of involvement define different clinicopathologic entities within this group. Plasma cell myeloma involves the multifocal accumulation of malignant plasma cells in the bone marrow and often presents with lytic bone lesions. It's typically associated with the presence of monoclonal immunoglobulin in serum or urine, known as monoclonal gammopathy. Some patients may have an asymptomatic phase with only mild bone marrow plasmacytosis, referred to as MGUS, which can progress to symptomatic plasma cell myeloma in about 25% of cases. Plasma cell myeloma exhibits marked bone marrow plasmacytosis, often exceeding 30% of marrow cellularity. Neoplastic plasma cells can display atypical cytologic features, including a high nuclear-to-cytoplasmic ratio, dispersed chromatin pattern, and distinct nucleoli. In contrast to reactive conditions and MGUS, large aggregates and sheets of plasma cells are common. Immunophenotypically, plasma cells are typically CD19 and CD20 negative but positive for CD138, CD38, and monoclonal cytoplasmic immunoglobulins. They may express other markers like CD56 and myeloid markers. Plasma cell myeloma primarily affects older individuals, with a median age of 70 years. Common clinical features include bone pain, pathologic fractures, hypercalcemia, renal insufficiency, susceptibility to infections, and amyloidosis. Amyloidosis can affect various organs, including the kidney, heart, liver, and peripheral nerves. Prognosis is related to factors like the percentage of bone marrow plasma cells and overall tumor burden, and most cases have a rapidly progressive course with a median survival of 3 years. Asymptomatic monoclonal gammopathy, MGUS, occurs in less than 5% of individuals over 70 years, and 25% of MGUS cases progress to overt myeloma. Plasmacytoma is a localized, mass-forming, monoclonal plasma cell proliferation. It can present as a solitary bone lesion or involve extraosseous or extramedullary sites, often in the head and neck region. Plasmacytomas are typically responsive to local radiation therapy. Approximately 15% of plasmacytoma cases progress to plasma cell myeloma. Diffuse large B-cell lymphoma, or DLBCL for short. This is one of the most common forms of non-Hodgkin lymphoma, accounting for a significant percentage of cases. In this video, we'll explore its characteristics, including morphology, immunophenotype, clinical features, and prognosis. Let's get started. Diffuse large B-cell lymphoma, or DLBCL, is a lymphoma characterized by its large cell size, diffuse histologic growth pattern, and significant variation in cytologic appearance and immunophenotype. It's an important topic to discuss, given its prevalence, accounting for 30% to 40% of all non-Hodgkin lymphoma cases. DLBCL typically presents with a diffuse proliferation of large lymphoid cells, which are at least twice the size of normal small lymphocytes. These cells may have single or multiple nucleoli and ample cytoplasm. In some cases, you'll also find an admixture of background histiocytes and small lymphocytes. Immunophenotypically, DLBCL expresses pan-B cell antigens, but due to its origin from various stages of B-cell development, it can exhibit a heterogeneous co-expression of other markers such as CD5, CD10, BCL6, CD30, and CD138. DLBCL doesn't discriminate by age, affecting individuals of various age groups, from children and young adults to the elderly. It can manifest as localized disease involving a group of lymph nodes or in extranodal sites like the gastrointestinal tract, central nervous system, bone, and serous effusions. DLBCL is an aggressive neoplasm with a high proliferation rate, often exceeding 40%, making it more sensitive to multi-agent chemotherapy. Prognosis can vary based on clinical parameters such as patient age, disease extent, and the site of involvement. Recent gene microarray studies have also identified different subtypes of DLBCL, some with better survival based on the lymphoma's origin from follicle center cells. Burkitt lymphoma, a rare and highly proliferative form of non-Hodgkin lymphoma. In this video, we'll explore its distinctive features, variants, morphology, immunophenotype, clinical aspects, and prognosis. Let's get started. Burkitt lymphoma is a remarkable condition characterized by medium-sized, rapidly proliferating lymphoid cells with unique basophilic vacuolated cytoplasm. It's important to note that there are 3 distinct variants of Burkitt lymphoma, namely endemic, more common in Africa, sporadic, and immunodeficiency associated. One of the striking features of Burkitt lymphoma is the starry sky pattern it presents. This pattern is defined by numerous tingible body macrophages that phagocytose apoptotic debris due to the high proliferative activity of the lymphoma cells. Speaking of these cells, they are medium-sized with round nuclei, finely distributed chromatin, and small nucleoli. Their cytoplasm is deeply basophilic and highly vacuolated. Immunophenotypically, Burkitt lymphoma cells express several antigens like CD19, CD20, CD10, and BCL6, reflecting their germinal center origin. They also show surface expression of monoclonal immunoglobulin light chains. Importantly, BCL2 is absent, setting Burkitt lymphoma apart. A hallmark of this lymphoma is its very high proliferation rate, closely associated with a specific genetic translocation involving the MYC gene, referred to as T814, T28, or T822. Burkitt lymphoma's clinical presentation can vary significantly based on the variant. It may involve different age groups and anatomical sites, with common sites including the central nervous system, bone marrow, and peripheral blood. Notably, some patients may have Epstein-Barr virus, EBV, present. Burkitt lymphoma is a medical emergency due to its rapid proliferation, and the chemotherapy regimens employed for its treatment are significantly different from those used for other high-grade lymphomas. Cure rates for Burkitt lymphoma can range from 60% to 90%, depending on the disease stage. However, it's essential to be aware that immunodeficiency-associated Burkitt lymphoma, which occurs predominantly in HIV-positive patients, tends to have a less favorable prognosis. Stay up to date with our latest videos by hitting that subscribe button and activating notifications. Be the first to know when we release new and exciting content. Don't keep all this valuable information to yourself, share this video with your friends who might find it interesting and beneficial. If you have any questions or comments, feel free to leave them down below. Until next time, take care and goodbye.